Thanks everyone. I'll be just speaking briefly about a small program of work that's been undertaken in southeastern Sydney. Really the genesis of this work was under the Southeast Sydney Integrated Care Strategy to see, is it feasible to use the patient activation measure, I guess to sort of inform both the outcomes of integrated care programs, but also to use it to tailor and guide care. So what is patient activation? It's a terrible jargon term in a sense. It sort of encompasses a range of, I guess, knowledges and skills linked to concepts like self-efficacy, but essentially it's the knowledge, skills, and confidence to manage and be involved in your own care. So it sets out, there's actually, using this patient activation measure, identifies 4 stages of activation. So there's the lowest level is sort of recognizing and understanding that, you know, your role in your own care is important. The second is to learn and develop the confidence to actually do that. At the 3rd level, I mean, this is my paraphrasing of the levels, is actually acting on that, you know, so doing something about that level of activation. And then 4 is reaching the stage where you're able to still maintain that degree of control and involvement in your own care, even when you're stressed or under competing demands and pressures. So why does it matter? It's been shown through numerous studies, and patient activation is really exploded as an area of study. There's, and I'll speak further on that. But, you know, it's been shown through numerous studies to be associated with medication adherence. Lower activation has been shown to be associated with higher rates of ED presentations and higher rates of hospitalisation. So the measure itself has been it's a tool that's been developed to gauge these skills and knowledge. It segments them into those 4 levels, but they use slightly different terminology around those 4 levels of activation. This is what it looks like. It's a 13 question scale. And as I mentioned, you know, this is the sort of formal definition of those 4 levels. We can see, the reason I paraphrased them earlier is that some of the formal language used to categorize them, people struggle with a little bit, you know, so the highest level actually has difficulty maintaining behaviors over time is the sort of formal characterization of it. But what that means is maintaining that sort of level of activation and control, even in the face of adversity and challenges of life and multimorbidity and those sorts of things. So the rationale for looking at this is that PAM has widely been used as an outcome measure. Internationally, it's gotten a fair bit of traction within particularly studies of self-efficacy, self-management and activation. Less evidence out there about PAM's ability to be used as a tool or to sort of guide and inform and tailor care. So really the bulk of the evidence is about using it as this outcome type measure. So really we were interested in testing the feasibility of using PAM as part of, I guess, a suite of integrated care work that's happening in Southeast Sydney. So the study had 3 phases. So it looked at scoping literature just to understand what is the nature and the use that's occurred in terms of, with specific reference to this tailoring, using PAM to tailor care. A retrospective audit of a service that had been using PAM for several years to see what kind of impact it was having. And then a pilot study with 3 teams within Southeast Sydney to look at, you know, how could PAM be used within a real clinical context to improve the quality of care. So how has it been used? As I've sort of alluded to, what we found, and this is just currently in the death throes of a review process, this paper, is that where PAM has been used for purposes other than as an outcome measure, it's primarily been as a tool for tailoring care, so how it can inform some clinical discussions and interactions, but also as part of I guess, a risk profile that might be generated for people. So PAM's also been used as an input into something akin to maybe a risk stratification type approach. It's worth mentioning though, that for this study, we found that, you know, there's now several thousand studies that have used PAM. The body of literature that's looking at this sort of tailoring is more in the realm of 30 to 40 studies. So it's really a subset of use. So the overwhelming body of evidence around PAM and its use is as a robust outcome measure, less about how can you actually use it to guide and inform care. So this retrospective record audit looked at a pulmonary rehab setting where they'd been using PAM as an outcome measure within the service for a few years. There was 118 people who'd completed the program and so had before and after measures for the PAM score. The mean score at baseline is 60.5, which puts that in that, if we think about those 3 levels of activation I mentioned, it puts it in that taking action sort of space. So there was probably a moderately high level of activation. These weren't people necessarily who were all struggling to act on their needs. The study showed that, the retrospective audit showed that, the PAM score had improved over time, but it was still within that level 3. So the reason the levels are sort of meaningful is this is the kind of interpretation you need to do to actually figure out how it can guide and inform care. The raw score itself isn't necessarily meaningful. It's like, how do we interpret and act on those scores? And the audit also showed that levels of anxiety and lung information needs, so this is another standardized instrument, were associated with lower levels of activation, and quality of life was associated with higher levels of activation. And that's been published just this year. The third phase was a pilot study that had a range of data points and included both a patient survey, but a range of qualitative measures that was undertaken as well. If I just sort of, and that's with 3 teams, so I'll mention that in greater detail, but if I wanted to give a summary of the qualitative findings we found from trying to trial the use of PAM, many of the issues faced are similar to those faced for adopting all new clinical practices. And I've mentioned normalization process theory that Tom mentioned earlier. That was the analytic frame, and a lot of what we found were the barriers to practice were not entirely novel just to PAM. It is like it's a new practice, a new thing. But there are also tactical and practical challenges to the use of PAM, and I'll go into further detail about what those are. The challenge also is making, if we think about this sort of 4, levels of activation, making that meaningful within the context of a clinical encounter is not straightforward. The teams that we were piloting it with were all teams that had a lot of experience in essentially rehab and community sort of interactions between community services and post-hospitalisation. They're skilled at use of motivational techniques and interviewing and so on. So they're not even, this is well within their wheelhouse in terms of area of practice. And if these people found it was hard to make it meaningfully integrated into their area of work, it's not a straightforward fit. It doesn't slot nicely into routine practices. In terms of the survey findings, what we found is we looked at the PAM score, and that showed that there was a significant change, and people again shifted from a little bit higher than in the quantum of improvement across those 3 teams than in the retrospective file audit. But we also used a scale called Partners in Health, which looks at, I guess, ability to engage in partnership with care teams about self-management and so on. So this was developed in Flinders University and has been used to a certain extent, but not as widely as PAM. But it provides an alternate way of thinking and looking at this sort of ability to be involved in your own care and self-management. And that also improved. But what was interesting was when we compared the PAM scores with these Partners in Health scores, despite both changing and improving, they didn't correlate. So in a sense, what that meant was that PAM and Partners in Health as ways of measuring activation or ability to be involved in self-management improved, and they were associated, but that change in PAM score didn't predict what your change in Partners in Health was going to be. So this suggests that PAM, to me, this is an interpretation of the findings, PAM might have been, and Partners in Health, could have been associated with other things going on, so it could have been underlying issues like socioeconomic status, aspects of health literacy, education, or just general health status, which we didn't measure through the pilot as the primary measures. But I think the real message I wanted to sort of convey from that is that there's more at play here than just a simple and simplistic conceptualization of activation. You're not sort of like switched on or switched off. You're not just able to self-manage or not able to self-manage. You know, there's more at play, and more at play in determining why you can be involved in your care. So if I think across all three, the so what factor, the three phases of the study, is the barriers and facilitators were the critical role of clinicians in terms of, you know, people aren't going to use PAM, for example, if they think it's not valuable within the clinical encounter. Tailoring care and responding and thinking through the implications of those differences in levels of activation is actually quite a high level clinical activity and needs a lot of clinical experience. And, you know, the teams that we were working with had that. But it was still a challenge to get them to think through, how do I use this information then to respond to how I offer care? Completing workplace demands as apply to all sorts of new practices that might be introduced. I think one of the issues was the ease of understanding the PAM questions. PAM, and I'm conscious there's people like Uday in the room who've used it in other contexts, in other countries and settings. Some of the PAM questions they're not always easy for all people to understand in all settings. And the challenges of calculating this score in a clinical setting, unless you've got something that does the back-end calculation for you, it is a bit of fiddling around, you know, and who has the time to do that within their care context, particularly if you want to use it to inform, you know, your interactions as you're having them. You know, you can't go away and think about it and come back for the next, use it to inform the next time you have a discussion, because often that can be weeks apart. So some other reflections is this has been a small study, so I'm conscious that PAM is widely used and there's other people exploring this space. So we don't want to overstate the findings, but I think the use of PAM to guide and tailor care is really a work in progress. You know, a lot of the attractiveness of PAM is that it's a robust outcome measure and that there's enough evidence to sort of suggest it's a nice proxy for things that will lead to lower levels of ED and presentation and hospitalisation and so on. But, you know, that's the attractiveness of it, but how to actually implement it in real clinical encounters is a bit more ambiguous. The challenges that we found that were a bit more, they were bigger issues than I'd anticipated going in. Language and literacy barriers, obviously, but even specific language and literacy issues in the context of these standardised scales. And the fact that PAM has been translated into a range of other languages, but how to get your hands on that quickly in a clinical context is challenging. And also the degree to which they've been validated and its use has been validated in all those settings. Yep. The other challenge is when people were unwell. One of the teams was a pulmonary rehab setting, and there was actually quite a degree of variation in basically how crook people were when they were involved in the program. And it can actually be quite challenging for really unwell people to just get through the 13 questions. And I think integrating PAM within established programs didn't necessarily slot in as nicely as we might have foreseen or imagined going in. And that might just be my naivety. One of the things that's really also interesting, and I think speaks to this issue of targeting, is PAM could notionally enable the more efficient targeting of activities and resources to people who might have lower levels of activation. But certainly my reading of the literature is that it's not clear empirically where your best bang for the buck is in terms of investing your time. Should you be working with the people with the lowest levels of activation, you know, that stage 1, or is it better to think about the stage 2 or 3 in terms of, and so there's not an empirical basis for that. So we need to have a clear values and equity driven discussion about that, you know. So where should we be investing our efforts, both as individuals and clinicians, but also services? And that's not straightforward. And that's part of the challenge of the tailoring sort of picture. So I just wanted to acknowledge really the fantastic collaborators on this, in particular the 3 teams, the cardiac rehab, the respiratory coordinated care, and the IREAP team. So they were really critical in giving us some insights into this. So thank you very much.